All right, let's talk about the distal radius fracture. It's one of those topics that's, well, pretty much guaranteed to come up in your orthopedic exams. I mean, it makes up almost 18% of all fractures in adults. So getting this right isn't just about scraping a pass. It's about sounding like you're already at that consultant level. So today, we're going to build the perfect Viva answer from the ground up, making sure you're ready for whatever the examiner throws at you.
Okay, so here it is, the classic Viva opener. A 65-year-old woman fall on an outstretched hand. Talk me through it. This is it. The examiner wants to see if you're systematic, if you're safe, if you're comprehensive. Everything we're about to go through, this is your answer. This is how you're going to ace this question. So let's dive in. Look, a great Viva answer is all about having a solid structure. It shows you can think clearly under pressure. So here's our game plan. First, we'll nail the opening statement. That's all about anatomy and the x-rays. Then we'll frame the injury with the right classification systems. After that, we'll get into the nuts and bolts, the management plan. And to finish strong, we'll cover some absolute Viva gold, the pearls and pitfalls. That's our roadmap to a definite pass. So how do you start? You need to sound safe and systematic right from the get-go. You'd say something like, first, I'd assess the patient clinically using ATLS principles. You have to mention a focused neurovascular exam of the hand, paying special attention to the median nerve. That's a must. Then you'd say, after I've reviewed the radiographs, I describe them using 3 key parameters. Boom, just like that. You've shown the examiner you're methodical and you know what you're doing. Okay, first up, the lateral view. You have got to talk about volar tilt. Think of it as the natural forward slant of the joint surface. It's so important for how the wrist moves, especially for flexion. And, the most common thing we see is a loss of this tilt. When that happens, it seriously messes with a patient's function. We're talking about simple things like turning a key or picking up a pot suddenly becoming really difficult. And the number you need to have locked in your brain is 11 degrees. That's your normal volar tilt. When you lose that, or even worse, when it flips into dorsal tilt, that's when you see big problems with function and grip strength. And here's the money number for your Viva. After you've reduced it, if there's still more than 5 degrees of dorsal tilt, that's generally considered unacceptable. You absolutely have to know that number. All right, now let's switch over to the AP view. The next thing you're going to talk about is radial inclination. This is the angle that shows how the radius slopes down toward the thumb side. Why does it matter? Because it acts like a buttress, a little shelf that literally holds the carpal bones in place and stops them from sliding off to the ulnar side. It's a critical piece of the puzzle. So what's normal? You're looking for a good 21 to 25 degrees. If you see that angle has been flattened out, that's a huge red flag. It's telling you this is probably an unstable fracture, and you're already starting to think, this is likely going to need surgery to rebuild that support. Without it, you're just asking for long-term risk problems. And the last of our 3 key measurements, still on that AP view, is radial length, or you can talk about it as ulnar variance. They're 2 sides of the same coin. Basically, the radius should be longer than the ulna at the wrist. We're talking about 9 to 12 millimeters longer. When that radius gets smashed down and shortens, the ulna becomes relatively too long. We call that positive ulnar variance, and it can cause this really nagging pain on the ulnar side of the wrist called ulnar impaction syndrome. It's a classic cause of ongoing pain, so you've got to spot it. Okay, so you've just masterfully described the x-rays. What's next? You have to classify the fracture. This shows the examiner you can organize your thoughts and it sets up your management plan. You'd say something like, while there are several classification systems, the 2 I find most helpful in this scenario are the Freichmann and the Fernandez. And it's really smart to not just name them, but to quickly explain the difference. So Freichmann is all about the anatomy. Which joints are involved? Is the ulna styloid broken? It's descriptive. Fernandez, though, is all about the mechanism. It's about how the fracture happened. Was it a bending force? A shearing force? And that's a much more modern way to think, because it helps you figure out the best way to fix it. It's more than just a label. Now, you've got to know the Freichmann classification. No getting around it. It's a bit of a memory test, I'll admit. It breaks things down based on joint involvement, radiocarpal, DRUJ, or both, and whether or not that ulnar styloid is fractured. Honestly, in our day-to-day practice, its direct impact on treatment is a bit limited, but for the exam, it's considered core knowledge. You just have to know it. But the Fernandez classification, this is where things get really practical. It actually helps you think about the surgery. For example, a type 1, a simple bending fracture, maybe you can get away with some K-wires. But a type 2, a shearing fracture? Think of a Barton's fracture, that classic fracture dislocation. Well, that thing is unstable by definition. It's sheared off. it needs a buttress plate. You see? Understanding the mechanism immediately points you to the solution. You're not just naming it, you're understanding its personality.
Right. So we've described the x-rays, we've classified the fracture. Now it's time for the main event, the management plan. And it all boils down to one key question. Is this fracture stable or unstable? You're going to use all the information you've gathered so far to make that call. And this is what the examiner is waiting for. They're going to ask, so when do you operate? And your answer can't be wishy-washy. The decision is based on cold, hard numbers, the radiographic criteria for what we call an acceptable reduction. If you can't get the fracture to sit within these limits after you've pulled on it, then it's unstable and it's time to talk about surgery. Knowing these numbers is absolutely non-negotiable. So here they are. These are the numbers to burn into your memory. Less than 5 degrees of dorsal tilt, less than 5 millimeters of radial shortening, and crucially, if it's in the joint, less than a 2 millimeter step off. If your closed reduction can't hit those targets, or if you know it's just going to collapse in the cast, that's when you have the conversation with the patient. You explain that surgery is the best way to restore their anatomy and give them the best shot at a good long-term outcome. Now, when you talk about surgery, you need to lay out the main options. You've got CRPP, closed reduction and percutaneous pinning, which is great for some of the simpler extra-articular patterns that you can hold with just a few wires. Then there's the workhorse, ORIF with a volar locking plate. This is what we use for most of the unstable intra-articular fractures. And finally, you've got external fixation. You save this for the really nasty stuff, high-energy fractures, severe comminution, open injuries, where you just need to hold everything out to length while the soft tissues settle down. And for bonus points, you've got to mention the key complication for each. That shows real depth of knowledge. Okay, we're in the home stretch. To really stick the landing and turn a good answer into a great one, you need to wrap up with some key concepts, the pearls and the common pitfalls. This is what separates the trainees from the consultants. It shows you're not just reciting a textbook. You've actually thought about the nuances of this injury. And here are some of those buzzwords that really make you sound sharp. When you're talking about external fixation, drop in the word ligamentotaxis, using the ligaments to pull the bone fragments back into place. When you're talking about volar plating, mention the watershed line, that critical ridge you don't want your plate to go past. And for a 65-year-old woman who fell from standing height, you have to call it what it is, a fragility fracture. That shows you're thinking beyond the wrist and about the patient's overall bone health. Knowing what to do is great, but knowing what not to do is just as important. You should almost list these out for the examiner. Forgetting to check the median nerve, huge mistake. Ignoring associated injuries like a TFCC tear, bad miss. And in this specific patient, not mentioning an osteoporosis workup is a fail. You also want to show you're up on the latest evidence. That's where you bring in the draft trial. It's a landmark study that showed for patients over 65, fixing them with a fancy plate didn't necessarily give them a better functional outcome at 1 year compared to just a cast. That's a huge talking point and shows you read the journals. And a really slick way to finish, you could almost turn the tables a little and pose a thoughtful question back to the examiner. Something like, for an elderly, low-demand patient, is a perfect-looking x-ray more important than a quick functional recovery? Because that's the real dilemma, isn't it? We're obsessed with getting a perfect reduction, but high-level evidence like the draft trial forces us to ask if that perfect x-ray actually matters for that specific patient's function. It shows you understand that the goal isn't just a pretty picture, it's a happy patient. And that is how you absolutely crush the distal radius fracture viva.